Hello and welcome to a new semester of EEG review. So this is EEG review 2, EOL234. You can expect the same format as in part 1, where I will review an EEG every week and you will report an EEG every week. And as you know, each week we have a certain topic. This week our topic is artifacts. And artifacts in EEG are important because they make up, or the frequency of artifacts in EEG is high. You actually would be hard pressed to find an EEG recording 30 minutes or longer that didn't have some kind of artifact, and that could be environmental artifact or physical artifact from the patient, from eye movements to head movements, from environmental factors such as an IV drip or somebody walking by the patient and knocking into the electrodes. There's all kinds of artifacts. So just to review, the two types of artifacts are like an anatomical artifact, and there's an environmental artifact. Okay, so what I'm going to do is review this EEG, which is EEG 2. I'll point out the various artifacts, but there's one main artifact in here that's of interest, and I'll point out that in EEG 1 there's also a main artifact of interest. So I'm looking for in EEG 1 is something other than simple EKG artifact or eye movement artifact, okay, that you would typically see on every EEG. I want you to find sort of a more of a unique artifact that you might only see for the first time on that EEG. So make sure you hunt a little bit and figure that out. But then again, I'm going to go through this EEG very quickly. These EEGs may not be normal, so I also want to go through and find or describe whether this EEG is normal or abnormal, and describe why. Okay. So here we're starting the EEG. We have a nice calibration page, and that's worth to look at the history very quickly. 29-year-old female, Goldhar syndrome. You have to look that up, but with rotary nystagmus, okay, which is spelled wrong, but so rotary nystagmus is an uncontrollable eye deviation or eye movement, okay, and she also has episodic dizziness, and these spells come with nausea. The EEG is being done to rule out seizures. The last episode of the dizzy spells was, you have to compare the dates of this recording to last attack on the 29th. Okay, so this is just yesterday. Alright, so the patient just complained of having dizziness yesterday. While the patient was in the elevator, she felt like the world was moving and around her head, and lasted about 1 minute. She has no previous EEG. Alright, so we'll take a look at the EEG, see if there's anything epileptiform in here that might suggest a seizure disorder. Alright, start off with the calibration page. You have nice calibration. All the channels are deflecting evenly. Notice that it also starts off with a brief biocal, which we don't use biocal for digital equipment. Alright. Looking at A1, A2, so what do we have here? Looks like there's some extra eye monitoring channels, and I guarantee you that they're probably not plugged in. They were just accidentally left into the montage. But what we have is, we start off with our IPSI ear reference. Alternating IPSI ear reference, comparing left to right on each channel. Notice that if we're going to talk about artifact, we do have a lot of artifact. We have a lot of these slow waves here, most likely from eye movements here. We also have a lot of EKG artifact. Okay. Here's a technical tip for you. If you're trying to run on an IPSI ear montage, referential montage and you have a lot of EKG artifact that you just can't get rid of and it's just overwhelming, what you can do is use what's called a linked ear reference. What a linked ear reference will do is I'm going to draw that out for you. Okay, so what you can do on a linked ear reference, I'm just going to basically type out, let's see if this will work. So what you have is, say you have your channel F4, and what happens in a linked ear, so that's ear input 1. Input 2 of the channel will be A1 plus A2, okay, and then divided by 2. And what your digital machines have is you should have this option to have a linked ear reference. And what happens is it takes the A1 plus the A2, which have the contaminated EKG signal, and it cancels it out, because what it does is it divides these two together, effectively canceling out and removing the EKG artifact. It's a pretty neat tool. So remember that if you have a lot of EKG artifact in an IPSI ear reference, try using the linked ear. It's called linked ear, which is A1 plus A2 divided by 2. So you're getting the average of these two in input 2. All right. Moving along. So there's a lot of artifact here. It's fairly hard to read. There's a lot of, look at this, a lot of slow activity, which it's primarily coming from the front. So we can say it's most likely some kind of eye movement artifact here. All right. Here, a tech made a note of a lot of lateral eye movements, very apparent. Okay. So this montage actually isn't helping us all that much. If we wanted to actually just quickly see if they did an eye opening, eye closing, they didn't. They didn't do a true eye opening, eye closer test during A1, A2, but that's okay. Why don't we go, I just want to jump right to the bipolar. All right, so looking at the bipolar, first off, this is the first page that we can look at. Now, if you remember the polarity eye polarity example I used during our online meeting, you'll remember that, or the assignment, the eye monitor assignment from last semester, the homework assignment, that you can determine left and right eye movements, or which way the eye moves. So in this case, we know that the eye moves to the right because the positive is over here and the negative is over here. Remember, the front of the eye is positive, and the positive goes towards the direction that the eye moves. So we have a lateral eye movement here, and we have a lot of lateral eye movements here, kind of slow roving, so maybe the patient's drowsy there. And I would say that the patient is drowsy because you can actually see a waxing and a waning in the background. This section here would be attenuated versus over here. Okay, and we also have this kind of bursty, sharp stuff. We'll have to keep our eye on. You see how that kind of comes out of the background a little bit. Okay, what I want to do is get to, okay, so let's see, patient scratches their nose, and we get a lot of this high amplitude delta activity, which is eye movement, and it happens to be lateral eye movement, left, right, or it could be just moving in one direction as well. But notice wherever we have a positive on one side, there's a negative. Same thing over here. You have a big positive and there's a negative over here. These are coming over each other, so they're going in the opposite direction, where these are pushing away from each other. All right, so we have lateral eye movements. Now, if you simply go back to the history gave you the hint. So this EEG's artifact happens to be a lateral nystagmus. So if you were to write a report on this, that's what I would hope that you pulled out, is that this EEG shows a lot of lateral nystagmus eye movements. And you can see it when it does occur. Notice this is probably when the patient opens their eyes. It gets a little bit uncontrollable here. But when it does occur, it's really a striking artifact, right? I mean, it really obscures or draws your eye away from the rest of the EEG. All right, but now that we see it, what we can do is start, or once we have identified it, we can start looking at what the background is here. All right, we know the eyes are closed at this point. If you look at the alpha background, which it actually is pretty nice. It's symmetric, both sides. If we count it out, I like to hand count it just by a visual. So you have like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, even probably 10 to 11. Nice background. And let's go back to an eye closure request. Let's go to eye opening request. I think the eyes are already open here a little bit. We'll get a better example. Most likely like right here. I think the patient's peeking here and there. But you can see a nice reactive background where you have alpha here and then it attenuates here. Again, all this frontal activity is eye movements. If your eye movement artifact was really high amplitude to the point where you can't really focus on the background, well, then you can start using your filter settings. Now these are about 2 hertz waves or so. So if I go to a 3 hertz filter, we know that a 3 hertz wave will be attenuated by 20%. So a 2 hertz wave would be attenuated by a little bit more than that. You'll see that the amplitude will be cut down a bit. It's okay to use your filters as long as you understand why you're using your filters and what your filters are doing to the activity. So always keep in mind. Now if I went to a 5 hertz, it would attenuate those waves even further. Again, so if these were 2 hertz, now probably a little bit longer than that, but say these were 2 hertz waves, we know that by using a 5 hertz filter that they're getting cut off, the amplitude is being knocked down by a little bit greater than 50%. You have to go back to your frequency curves to get a good understanding of that. Very important stuff. Okay. I'm just going to move along here. And notice, all right, so we have our alpha background. Then we have this bursty stuff in the temporal regions to keep an eye on. Something that we'll need to define in the end. Start some HV. We'll see if there's any significant buildup. Again, a lot of lateral nystagmus here. And here we have, I mean, we can call a little burst, I guess, but and here again. But notice that these do look very sharp, right? Here we have it a little more left than on the right. They look sharp. They're about, if you're going to measure them out, they're still in alpha frequency. They're probably somewhere around, you know, 9 to 11 hertz or so. They come in a little run, all right? And here within the eye movement, there's a little burst, but it's kind of obscured. And here again, could be a little effect from HV, so we just have to keep an eye on this. And more here. Patient's getting a little drowsy too. You can see a little bit of waxing and waning of the background. Here again, I'm just going to highlight this real quick, just so we know what everyone can visualize what I'm doing. If I push the right buttons, hold on. Okay, fine. So it's gonna highlight this section here just for a moment. In this case, we have, it looks pretty symmetric as far as bilateral temporal, sharp or spiky. Alright, now I'm just going to give a hint and say that this is actually a normal variant that I'll describe very shortly. I don't know if you can maybe try to think about what normal variant this might be. The thing that's important to note is that even though these are sharp, they don't have that disruptive quality that an epileptiform wave has. If you remember, you have a spike and then a wave, or a sharp and then a wave. If you go back and look at these do not have that. They do phase reverse. They're phase reversing at T3 and they're phase reversing at T4. Remember, just because something phase reverses doesn't mean it's abnormal. This is a little bit more than what we just saw on the page before. So there is so this occasional burst of sharp, high amplitude theta. This is bilateral. It's almost, I guess you can say it's almost a short 1 second generalized little burst of activity there. Epileptiform, I'm not going to call it that right now. Here we have suppression of the posterior rhythm, so we have drowsiness here. More of the activity that I mentioned before, this time more right than left. More eye movements. This I almost want to say transitional burst of theta when I get into drowsiness. Sharp. Here again. The stuff around T4. Bursty stuff. Alright. Getting into drowsiness. More of this. Okay. So right now I'm going to just describe it. This is what you would call wicket spikes. Okay? And wicket spikes are a benign EEG variant. They're considered normal. They have no clinical significance. They have no relation to epilepsy or any other known disease state or abnormality. Okay, so they've been defined as a normal variant. Wicket spikes have a tendency to, you can see them on the same side. Excuse me. You can see them bilaterally, temporally, synchronous with each other, or they can come in runs independent on the left or on the right. Okay. Sometimes you'll see a little run on the left and maybe a follow up on the little run on the right. They usually come in a run about 1 second. 2 seconds is probably a little extreme, but you'll see them coming these short little 1 second runs. Notice they don't, as I mentioned before, they don't have a slow wave following them. They're much more of an awake pattern, but as you can see, also in transitional sort of awake, drowsy, and they do go away in stage 2 sleep. So now that you have defined them, you can actually start to see that they're pretty frequently there. All right, and they come at slightly different frequencies here and there. I think we had some more of a alpha hertz variety, and these are more, if you were to measure these, are probably more of a theta down at the base. Yeah, this is 6.97 hertz. That's theta range. In any case, they have a very sharp or spiky top, so that's why we call them wicket. Wicket, because they look like wickets, top of a fence, spikes. Okay, moving along. Patient's getting a little more drowsy here. Starting to see vertex waves, especially right here. Phase reversing at CZ across the vertex. Also see, if you look closely, which might have been hidden a little bit before, is if you look at this EKG, you'll see that there's actually an EKG artifact, especially in the right temporal chain. Okay, here. All right, something to make note of. More drowsiness. These S's here, the tech did this because the patient was snoring. There are some sleep spindles back in this area, but here, right here, is a great example of some nice sleep spindles. Sleep spindles are about 14 to 15 hertz per second, and if I can fit 3 of these in 1/5 and times it by 5, that's my range. That's my frequency. 1, 2, 3. Okay, but also spindly, where the name comes from. Stage 2. Patients in stage 2 sleep. Some wickets here, even a little bit of stage 2. Okay. Nice sleep spindles, nice vertex waves, patient snoring. Oh, nice wickets right here. A little bit of arousal actually, but nice wickets on the left. Still snoring. See, wickets can sometimes be a little confusing when they come in a run of 1 or 2, because now you just see this 1 and it makes you think, oh, it's a little bit more suspicious, as if you had a sharp or spiked transient. Sometimes they look like this, but we know that what we've seen throughout this study is that the patient has wicket spikes. So, and as you can see, this comes in a run of 2. Nice wickets here. So I take back what I said about not being able to see wickets in stage 2, because we had some clear ones in right here. Nice stage 2 sleep here. Nice, very nice sleep spindles. A lot of vertex activity going on here. Okay, moving along. Notice that the nystagmus is, for the most part, well, it's interesting. It's still here, right? The patient's not in REM sleep, but you can see that this is a right eye movement. This is another right eye movement. Another right eye movement. Okay, so it's there, but notice when the patient wakes up how much more dramatic those eye movements become. All right, a lot of stage 2. Again, wicket spikes. Take a mental image of those because you'll see them quite often. Could be a K complex, or just maybe getting a little bit deeper into stage 2. This is a pretty long sleep recording for a routine EEG. Okay, patient just arose. Tech called the patient. Wakes. Has a nice alpha rhythm here. Eyes closed request. Here they actually did close their eyes. Nice background. Lateral eye movements. Just folding your head a little bit more. Again, wicket spikes there. Alright, getting it into photic. A lot of lateral eye movements here. A lot of artifact. Alright, we're just going to look at some photic here. What's difficult about this, I wanted to see if we could pick out photic at 1. The little difficult is the fact that we have EKG artifact at almost the same time. So unfortunately, we can't just go and doesn't say as they're driving at 1, but let's just move along. 3, nothing too significant. 5, nothing too significant. I'll stop when I see something significant. How about that? Maybe a little bit here at 9. 11, close to the alpha background, tough to say. 15, 13, definitely. Okay, you see a nice photic response right here. Nice photic driving. 15, absolutely. 17, yes. We can go to our photic montage actually. 30, believe it or not. Okay, so nice driving response at especially the higher frequencies. Remember, driving response is neither considered normal or abnormal to say per se have driving. So in an otherwise normal EEG, if someone didn't have driving, it's not an issue. Excessive driving can show sort of hypersensitivity, which can sometimes mean can be found in patients with a migraine history when you see a lot of driving. Obviously, we do photic stimulation to see if someone is photosensitive. If they have a paroxysmal response, so if they have a certain type of epilepsy that is triggered by a certain light frequency. So that's obviously a reason we do it. But the other finding would be is if there was a significant asymmetry in the driving on the left versus the right. All right. And that is it for this study. So again, the major artifact in this study was, and if I was having students do the reports, which I had in the past, is I was looking for that the artifact in here was an example of rotary nystagmus, all right, which was horizontal left and right eye movement. Secondly, overall, this EEG was fairly normal. What I'd actually like to do is go back to what we were calling those bursts, because actually I'm going to change my mind. So yeah, looking back at this burst activity, is it wickets or is it something more? I'm leaning towards it something more, so I'm going to say that this EEG is abnormal because of this bilateral burst of irregular sharp theta. Okay, epileptiform, hard to say, probably not, but definitely we had wickets, which again are a normal variant, and I want to certainly press that you will see these fairly frequently on your EEGs. And think about it, when you see these runs come, and sometimes, like I said, they're independent on the left and the right, or they happen at the same time. If they're phase reversing around, mid-temporal region, and there's no slow wave following them, and they only come in a run of 1-2 seconds max, then they're wicket spikes, and they're a normal variant. Okay, so you can impress your fellow colleagues and your doctors by putting that in your tech report. Okay. All right, so that pretty much wraps it up on this EEG. I hope you found it educational. I will be posting a quiz as usual on Thursday to go over some of the key points that I found important during our review. Please email me with any questions, and I'll be talking to you soon. Thanks.